Hi, everybody. Welcome. This is Carrie Mahoney from the ARC of Massachusetts, and I want to welcome you all back for part 2 of Allison's webinar on understanding trauma and building trauma-informed supports. Allison Hrovat is a therapist, and she also is a professor at Holyoke Community College, and she has really dove into understanding the needs of people with intellectual and developmental disabilities in terms of trauma. So we're so excited to have her back, and thank you all for coming. So you've all been muted upon entry so that we're recording the session, and it will be available on our YouTube channel after the series, probably by the end of the week. And I hope the thunderstorms don't mess us up electronically. We just had a big thunder boom in where I am. So anyways, Allison, I will let you take it from here.
Great. Thank you so much, Carrie, and thank you all for being back. It's great to see some faces and to recognize some names from Tuesday. And so I'm going to just jump in today because there's quite a bit that I'd love to be able to cover, and I want to make sure to leave some time at the end for your questions. So just as a reminder, you can go ahead and put questions in the chat. You can either chat them to the group, or if you feel like it's something you want to send directly to me, I'd be happy to share the question anonymously on your behalf, and we'll get to those in the last 10 minutes of the presentation. So just to do a quick recap of where we wrapped up on Tuesday, we talked about the human brain, and we looked at the 3 different parts of the brain. The reptilian part of the brain, the most primitive part of the brain that's focused on survival, the limbic system, the intermediate brain, which is the mammalian part of the brain, or I like to think of it as the dewy brain. This is the part of our brain where we have emotions and learning. This is also the part of our brain that has our smoke detector, the amygdala. And this is the part of the brain that is accessible to us during traumatic stress or in the moment of a crisis. When our smoke detector goes off and says, danger, 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 our brain makes a decision to prioritize survival. And so the mammalian part of the brain and the lizard part of the brain are available to us. Primarily unavailable to us is the front sparkly part of the brain, the human part of the brain. And this is where we make sense of our experiences. This is where we apply a system of language, a system of meaning and context. And so all of these things that happen in our brain have a role to play in trauma. But most significantly, what's important is that we recognize that when some kind of traumatic stress happens, all of the things that we use to make sense of things, to put things in perspective, to make rational, logical, well thought out decisions are unavailable to us. And so what we rely on is our mammalian response, our dewy response. If you think about your cat and your dog and the ways that they're able to process what happens, that's what's available to us in the moment of trauma or traumatic stress or a crisis. So I wanted to respond to start to a question that was asked about what is the impact of experiencing trauma before someone is verbal. And what I want to say about that first is just give you a little bit of information about the way traumatic memory tends to work. Traumatic memory is a special category of memory. And what it means is that the memories that we have of trauma are necessarily different than memories that we might have of an event or an experience that's not traumatic. Why is that? Well, that's because when we're taking in the information from a traumatic experience, it's in that dewy part of the brain, which is separate from so much of the parts of our brain that we use to create memories. So things that help us to tell a story in order, things that help us to put things in sequence, the part of our brain that allows us to match up an image that we remember with a story or with some context. So traumatic memories are inherently disorganized. They sometimes don't make sense. And depending on the kind of trauma and the severity of the danger that a person experienced, they might feel more like a collection of tidbits than a coherent memory. snapshots, sensory memories. Remember that when we experience stress, our senses get heightened. And so a lot of the data that we take in is within our senses. So we might remember a sound, a smell, a taste, a touch. Any of those things might be, separate from us having a coherent narrative. So traumatic memories lack sequencing, they lack organization. They also are not always expressed well in words, because if you remember, when that human part of the brain gets shut down, that's the language part of the brain. And that's the complex language part of the brain. Our Dewey part of the brain has some ability to communicate in one way or another, representational language. So the sounds that your pets make to express, different emotions. But really specific language is unavailable to us when we experience a trauma, which is why it's so difficult to get a story of a traumatic experience that someone went through. So when we think about infants that are pre-verbal, and trauma is studied at all stages, even in utero, the impacts of trauma. But when we think about an infant that is pre-verbal, they are not they're not pairing language in any way with their experiences. So, it's not just that they can't produce language, it's that they're not experiencing language in the brain. They're not making a match between something that happens and a way of communicating it. And so what we know is that when people experience trauma before they're verbal, they experience it in a fully sensational way. So there might be body sensations, there might be motor responses that happen in response to the stress. All of those sort of bodily experiences, those sensational experiences, are likely to be how the trauma is represented. And so when we think back to the residue of surviving trauma and the idea that neurons that fire together wire together, this happens very early on in life. So if an infant experiences some kind of stress, for the sake of an example, let's say some kind of a medical event that separates that infant from their primary caregiver, they might have some sort of bodily response to that, a tensing in certain parts of the body, challenges with eating, with going to the bathroom and digesting and those kinds of primitive responses. And so the trauma might be coded in that way. We don't always exactly know, because obviously we're not taking brain scans of everybody when they are born and every month along the way. But a lot of times when I work with people who know that they've experienced very, very early childhood trauma, we explore those kind of body reactions and the way that the body and the senses hold those experiences. And so again, the most significant challenge for trauma survivors is the ability to live in the present. And I mean that in a very literal way. The brain of a trauma survivor, especially in the near aftermath of a trauma, is programmed to revisit that trauma, to still try and make sense of it, right? To still try and couple that very human, sparkly part of the brain with the mammalian part of the brain. So often when I talk to people who recently went through a traumatic event, they have this desire, this impulse to kind of walk through things and to try and put it in order, to try and make sense of it. Because sometimes the chaotic nature of traumatic memory is really hard to manage. And part of what can be difficult is recognizing that the cost of survival very often is that we don't have those sequenced memories. We don't have those organized memories. And so when we talk in a moment about trauma specific to folks with intellectual and developmental disabilities, this is where it's always been surprising to me that there hasn't been more dialogue about this connection, both because we know that trauma is common and because we know that the experience of trauma and the experience of healing from trauma is actually completely removed from a need to be able to fully express something verbally or to fully integrate something intellectually. That's not really a focus of the healing process, because of the fact that our brain is processing trauma in a much less verbal and linguistic part of the brain. So when we think about the challenges to living in the present moment, it's really that our brain is forcing us into the past to try and make sense of it. and into the future to try and anticipate a future threat, which makes it really, really hard to make decisions on or to make responses to what's happening in the present moment. This is why a lot of times when people are, when trauma survivors are startled, for example, tapped on the shoulder, something very simple, their reaction can be very explosive and very protective because their body is revved way up. And so that part of the brain that revs the body up doesn't factor in context. So that part of the brain doesn't say, don't worry, the only other person in the room is your best friend. They're not going to hurt you. That part of the brain is going to experience that tap on the shoulder as danger, 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 without an ability to take context into consideration. So when we think about all of this, the fact that it's really hard to be in the present moment, what also comes out of this is a really stark disparity between the survival brain and what we'll call the learning brain. And the learning brain is to say both the brain that wants to actually learn sort of concrete new things, but also the brain that we hope to have to just gain new experiences and to develop through life. So the survival brain is focused exclusively on threat. And that is the most important thing, is for that survival brain to detect threats and to be able to protect us, to be able to keep us safe. And so for that reason, it always errs on the side of suspicion. If there's a decision to be made between suspicion and trust, the survival brain is always going to prioritize suspicion. Why? Because any kind of ambiguity could potentially be dangerous. And anything dangerous could potentially be lethal, could potentially threaten survival. So the survival brain is panicked and fearful. It focuses on minute details that might to somebody else seem completely insignificant, but the survival brain hones in on those minute details as potentially being the difference between safety and danger, between life and death. This brain is fearful of making mistakes. Making a mistake feels catastrophic because the survival brain convinces us that if we make a mistake, it could lead to a deadly consequence. And so this part of the brain has a really hard time learning. It's really hard to take in new information because taking in new information requires patience. It requires us to sit with some uncertainty before we know things for sure. The survival brain doesn't want to look stupid. It wants to be sure of itself. Now we juxtapose that to the learning brain, which is the brain that really is what helps us develop through life. And the learning brain wants to be open to new information. The learning brain is comfortable with ambiguity. It doesn't need blacks and whites. It's very comfortable with gray. It's exciting to be able to play with and to learn new things. The learning brain is able to imagine new possibilities. And I think that that can be one of the sort of most heartbreaking things about the life of a survivor who's stuck in survival brain, is the inability to imagine that the future could look different than all of the tragedies of the past. And so the learning brain can imagine. It can imagine all kinds of things. It can be playful and exciting and fun, and it's not afraid of making mistakes. And so for a trauma survivor, the survival brain is always going to take over until we can create healing that allows that person to get into the learning brain. The longer someone lives in survival brain, the harder it is to get into that learning brain. But I would really say not impossible. Once we start looking at this intentionally and looking at the ways that we can create opportunities to shift into the learning brain, we can see that that's possible. There's a link here in the PowerPoint that you should all have access to. It's a really short video that explains the difference between the learning brain and the survival brain. I think it's a great quick tool to share with people to talk about sort of the immediate impacts of trauma. Oops. All right. So I think it's important to say that as much as we know about the impacts of trauma and how trauma can shape the brain, we also have that same amount of information about the impacts of recovery. We know that people can and do heal and recover and engage in a process of recovery from trauma. With new supports and interventions, with just looking at things differently, conceptualizing the way people engage and interact with others, we're able to think about ways to shift those pathways. The most important question for a trauma survivor to ask themselves repeatedly is, something here feels dangerous. Am I in danger, or does this just remind me of something dangerous? That very important question can be really hard to build in when our brain goes immediately from danger, danger, danger to response. But as we start building in that question and asking ourselves that question, even in the aftermath, we allow our brain to change that superhighway, that shortcut between alarm and reaction, to being able to consider the possibility that something might feel dangerous. This smell reminds me of a time that something scary happened, but I can check out my safety in all these different ways and know that I'm not in this moment in immediate danger. Okay, so we're gonna switch gears here to talk a little bit about trauma, specifically as it relates to intellectual and developmental disabilities. I want to say that in this part of the presentation, I really built in, hopefully, a lot of information. I'm not going to go through it point by point because I want to be mindful of the time today and getting to other topics, but I hope that it will feel like information that you can have for your own resources and for those that you support. I think that the most important things to say right up front is that we know that abuse, neglect, early childhood separation, early childhood sort of patterns of change of placement and provider can have profound impacts on brain development. One of the things that for a long time was kind of a pervasive myth is that children are resilient and that children bounce back from things because they're resilient. And children are resilient, but that is different than saying that children are unaffected by trauma. Wait, somebody has their hand up. Mandy, do you have a question?
Accidentally hit that.
Oh, okay.
I'm sorry, I was hitting the chat and everything, my bad.
Okay, thanks. I just wanted to make sure I wasn't overlooking you. Children are resilient, and resiliency is part of what helps people to recover from trauma. But resiliency is different than saying someone is unaffected by trauma. And it's really the wrong question in general, because the brain does not come to us built. The brain is built based on experiences. The brain is built based on interactions. And so the brain is shaped around the experiences. So we can never say that somebody is built resilient to something. What we can say is that if someone experiences trauma early in childhood, their brain is going to develop to incorporate that trauma in one way or another. The brain is going to develop to show the impacts of that trauma in one way or another. So one of the things that we know is that not only are people with intellectual and developmental disabilities more likely in life to experience trauma, but early exposure to trauma makes developmental delays, developmental differences, cognitive differences more likely and or more profound. So there's this very important connection between trauma and intellectual and developmental disabilities. And so it has always sort of begged the question, if that's the case, if we know that that relationship exists, why hasn't this been talked about? A lot of times, if we look at some of the earliest literature looking at trauma specific to folks with developmental and intellectual disabilities, what we see is that for a long time, there was just this diagnostic overreach, that this belief that someone's developmental disability explained everything, right? And so when we look at the kinds of behaviors and the kinds of communicative responses that might indicate trauma, we were seeing those things be simply attributed to the disability and not investigated any further. And so now that there is this recognition that not only do people with intellectual or developmental disabilities experience trauma, but that it has the same kinds of impacts on them, we're seeing more and more discussion of how we can incorporate a trauma-informed approach. So there's all kinds of research that has, been put out in the past few years looking at, in particular, the myths. One of the leading myths being what I just said, that for some reason, people with intellectual and developmental disabilities don't have the same kinds of responses, or that they can't benefit from therapy, including trauma-based interventions, that working with this population requires very, very specialized training that many trauma therapists don't have, and so, I don't know, so what? So we shouldn't somehow push through that question. Also a belief that if people are not verbal in their communication, that somehow that means they forget the trauma. If they have some kind of cognitive impairments, that means that they don't store the trauma in some way. And that any kinds of behaviors are exclusively explained by a disability. Also, that the a myth is that behavior modification is a really important intervention. And I think a big myth is that in order for people to heal from trauma, they have to be able to tell their story. This is a myth that has gotten even stronger legs in the era of social media, where it feels like people experience telling their story publicly as like the gateway to healing. And what I can say is that, knowing the literature as I do, and having gone to countless trauma trainings, this is sometimes a part of people's process of healing from trauma. But if we understand that trauma impacts the brain, and that the brain is inherently connected to the body, what we know is that trauma is in our body. It's not in our words. And so whether someone wants to or is able to share their story of trauma is not necessary for their healing process. So if we think about all of those things as myths, and I think that they are in some places pretty persistent myths. I mean, I can tell you I've worked at a lot of trauma-based community programs that have not historically done a great job in building bridges with developmental services in whichever community I've lived in. And part of that is these myths. Part of that are these barriers that seem to make this kind of work inaccessible. But when we really look at what helps people recover from trauma, these are interventions, these are adjustments that are accessible to absolutely everyone. So what we know, in fact, is that people with intellectual and developmental disabilities suffer from trauma in the same ways, and in very profound ways. That there have been many different approaches that have been shown to be effective. And when I say approaches, I'm talking about trauma therapy and like therapeutic approaches, but I'm also talking about just the broad spectrum of trauma-informed strategies that can help us work more effectively on just a daily basis with individuals who have experienced trauma. Trauma-informed approaches are so flexible. Once you understand the process that's unfolding in the brain and what happens with trauma, it creates a lot of different options for how you respond to it. There's not just one manualized treatment that can help people who have experienced trauma. There's so many different strategies. One of the things that we've seen as there's been more and more research specific to individuals with developmental and intellectual disabilities working in a trauma therapy setting is that while it might take longer to make gains, those gains that are made are enduring, that they're able to do the work of incorporating the trauma in the same way that any of us do. One of the other things is that, and I think that this is really an opportunity, so many times when I'm doing trauma trainings, the main thing that I'm trying to get across is that in a trauma-informed approach, the way people behave, the way that they react, the way that they, respond to stressors or whatever is communicative. And it is a resilient form of communication. It is their brain's best effort at coping with trauma and protecting themselves. And sometimes it doesn't look great. It looks reactive, it looks threatening, it looks aggressive. But all of you know from your work that the way people react is a communication, is an important communication. And so we have to honor that communication and help them to come up with a new way to cope with or communicate their safety needs before we just extinguish the behavior. You know, taking away a trauma-informed or a trauma-based reaction before we offer something else is taking away the way that the brain knows to make itself feel safe. And this is where I feel like the comparison to pets is really helpful. When you're trying to get your pet to stop doing some kind of behavior, the approach is to provide them with something else so that they might not need to engage in that behavior. The same thing is true when we're talking about trauma recovery for everyone, that when we're trying to get somebody to engage in a less, self-harming behavior, for example, we want to provide them with supports so that they're able to cope with the feeling that led to that behavior in a different way. All right. So we look at some of the challenges that are specific. One of the things that can be really difficult, and I'm sure you're far more aware of it than I am in your work, is a constant change of providers, of a constant change of caregivers. I know that that's not certainly the case for everyone, but for individuals who have experienced significant changes in settings, significant changes in the people that they work with, the people that they live with, that can be challenging. And one of the challenges that creates is an inability to have a consistent source of information. On Tuesday, when someone was asking about sort of how do we know what's happened, one of the best ways for us to be able to recognize the impact of trauma is to have a really consistent sense of who a person is and how they respond to stressors. And then when we notice differences, we can start thinking about how that might represent the impact of a traumatic event. One example that for me has always been really meaningful is a family that I worked with years ago. The gentleman was in his 40s. He'd always lived fairly independently. He had a social life. And all of a sudden, all of those things were being sort of rolled back. He no longer was able to be independent in his grooming and in some, he used to cook a lot of meals for himself, that he was no longer able to do that. He was not able to sort of successfully execute a lot of these daily living tasks that he'd been doing for a long time. And so somehow they came to see me at the mental health clinic where I was working. And his mom said that the doctor thought that they were going to be doing some further testing to see if something had changed cognitively. And once I started talking to him, what I found out is that his dad had died the year before, and that he had profound grief over the loss of his father. And when he started talking about what losing his father meant to him, what became really clear to me is that not only was he sad at the loss of his father, but he was fairly new in the realization that he would also one day lose his mother. And so at the time that he lost his father, he stopped being able to wash his hair, to brush his teeth. And what happened? His mom stepped in to do all of those caregiving things. And so if we look at this from a trauma-informed perspective, what was his behavior communicating? His behavior was communicating his fear that the world is unsafe, that people leave unpredictably. And so he wanted that caregiving from his mom. He wanted that chance to feel like she was actively involved in providing him with love and care. And so once we were able to start looking at his grief, all of a sudden things shifted. All of a sudden, he realized that there were other ways that his mom could show him care other than shampooing his hair, that there were other ways that he could feel connected and supported in his grief. Another challenge is that we don't see a ton of peer-to-peer support networks specifically crafted around the experience of trauma, specifically crafted around grief, loss, abuse, shared experiences. Now, that's a tricky thing, because in those peer support groups, the chance for re-traumatization is really high. So those groups need to be supported and they need to be facilitated. But we know that those kinds of groups show healing results. And so it's something to really think about. Another challenge is just, the stigma, people feeling underprepared either to address trauma or to address the complexities that someone might experience at the intersection of trauma and developmental disabilities. A lot of the evidence-based approaches in trauma in their research and development have really excluded this population. This has started to change. We're starting to see people specifically taking a look at this. But also to say that evidence-based interventions really only means interventions that have been tested out in research conditions. That there are so many, when I teach the trauma course at Holyoke Community College, when we get to the part of the class where we start talking about interventions, people are like, oh, I can do these things with my family today. A lot of these things are pretty simple, supportive interventions that can be put into place. Okay. So when we look at how do we recognize some of these, how do we recognize trauma? What are we looking for? I want to reiterate what I said on Tuesday, which is that to me, my perspective is that people should never be forced to tell their trauma, and to even really have to share with me whether they have experienced trauma. A lot of diagnostic assessments have just a question, trauma history, and people a lot of times aren't really ready at an intake to share that information. But it's also important to say, when we think about the fact that we're looking at potentially very, very early childhood trauma, people don't always know what their trauma histories are. People don't always know that they've experienced trauma. So instead, what we're looking at is the manifestations of trauma. Now, again, if we're working with somebody for a long time and they experience trauma in the period of our work, we're looking for a change from the baseline. But if we're working with somebody who may have experienced trauma earlier in life, we don't really know, what we want to look at really closely is the manifestations in the way that they engage with others. We want to just ask the question of whether some of the behaviors that they engage in, whether that's sort of self-harming behaviors or just repetitive behaviors, whether that might be connected to an experience of trauma. When we think about what the brain knows how to do to cope with trauma, the brain knows how to come up with a way to quiet down that trauma response. The brain does not know whether that dewy part of the brain doesn't know whether the thing that's chosen is healthy or unhealthy, is, socially acceptable, socially unacceptable. That's not a decision that's made in the trauma part of the brain. So we just want to ask the question, could this be part of a trauma response? And when we ask that question, what we want to consider is that if this is hypothetically part of a trauma response, then it is a behavior, a way of communicating, a way of interacting that has led this person to help this person survive. And so we want to treat it as such, as something that has been a resilient tool for survival. All right. So when we kind of pull the lens out a little bit and we think about the impact of trauma on support people, family members, and caregivers, what we know is that trauma impacts everyone who comes in contact with it. And it brings up all kinds of feelings and reactions and desires to protect and all kinds of things. And so the first thing that I really think is important is to recognize that trauma is an experience that impacts everyone. That blame and guilt and shame over not knowing the right thing to do, not saying the right thing, are just a rampant part of the trauma experience. And I think it's really important when I'm working with families, the first thing that I say is that no one gets this right. No one has the perfect answer. And that healing and recovery are ongoing processes. Just as if a parent or a caregiver had a kid who, you know, twisted their ankle, took him to the doctor, got the ankle wrapped, let the kid play a few days later when it was allowed and the ankle got re-hurt. Just like that is a process of healing where we don't always know the perfect moment to change course. So is trauma. It is something that we're always coping with in different ways. And so when we think about the way that trauma impacts families, what we also think about is the fact that any kind of trauma has the possibility of bringing up another kind of trauma. And so when parents and caregivers are faced with supporting their loved one through trauma, they're also dealing with their own experiences of trauma. You know, when I think about what's been happening with the COVID crisis, and as I've been teaching classes, and, you know, a lot of areas of Holyoke got impacted quite significantly. People are talking about grief and loss, but they're also talking about all the grief and loss of their life and how it brings back that feeling. And so the most important thing is for us to think about validating the experience of trauma. No one gets it right. And also validating the fact that trauma, by its nature, when we think about that learning brain versus the survival brain, is going to push us towards a place of suspicion and mistrust. And so if we can do anything, it's to start the work of building those trusting relationships, of building a sense of trust. You know, sometimes when I'm working with families, we don't talk about the trauma that's been experienced for a very, very long time, because the most important thing is that they feel like I'm a safe person who's not going to pressure them to do something that they don't feel ready to do. Vicarious trauma is an experience that in my mindset is not an if, but it's a when. When we spend time working with and supporting people who are experiencing trauma, the impacts of trauma rub off on us. And so the symptoms of vicarious trauma look just like trauma. All of a sudden, our brain is on high alert. Danger, danger, danger everywhere. I remember the first time I started working, or I was working for a long time in a family violence program, I would go out in the world and I would see families out to dinner and I'd wonder what was happening in their homes. I couldn't look at the world without factoring in this possibility of danger. And it was because I was so exposed to this one kind of problem that I was sort of seeing it everywhere. And so a vicariously traumatized person behaves like a traumatized person. They're more reactive. They're looking for the answer. They're looking to solve the problem rather than support the concern. They're looking to eradicate the problem, you know, eradicate the threat rather than be focused on a healing process. And so we want to try and recognize that within ourselves, within our colleagues, within the families that we work with, within the communities that we work with, and validate that this is not a failure of anyone to do their work well. It is the cost of being closely in contact with trauma. And the more we can think about it in that way, the more we can be prepared to respond to that. What research will show us is that people are filled with shame around vicarious trauma, and that people, when they're asked, what would help you to manage your experience of vicarious trauma better, people are most likely to say, it's something I'm not doing right. I'm not good at balancing. I'm all or nothing. You know I should work out more. I have that yoga DVD that I've never watched. I need to drink more water. People will come up with all the things that they're not personally doing right. But when we look at what actually makes an impact on vicarious trauma, it's whole system level change. It's whole system level supports and validation for everybody needing to be thoughtful and aware of this, everybody needing to support one another in this. So when we look at a residence, for example, when we have multiple people experiencing trauma and then other people experiencing vicarious trauma, what we're looking at is an entire community level support validate, to say these things are hard. We need to be intentional about creating time and space for people to have their reactions. We need to set boundaries around what's appropriate, and then we also need to listen compassionately and respond compassionately when people respond in ways that are maybe outside of the boundaries that we've set. All right, so I keep using this term trauma-informed, and so now I'm gonna break that down for you a little bit. Being trauma-informed is about putting on a different pair of glasses. I think that most times when people come to workshops, what they hope is that they can have, like, you know, a few things that they can start doing right away. And I'm going to give you some of those things. So those things exist. But more importantly is, like, what looks different in the world? What looks different in your life when you put on the lens of trauma? When you look at the patterns in your life, at the relationships in your life, at the stressors in your life, through the compassionate lens of trauma. And so what that means is that we want to have this understanding. So now you all have an understanding of what happens in our brain. And to me, when I'm struggling to get into a trauma-informed mindset, that's the place that I go. It's like, okay, let me break down what's happening in the brain. And when we do it that way, we start looking at things in terms of what impact or what consequences does, you know, this next decision have on people who've experienced trauma, or on myself, whoever you're focused on. And then the other question is, what supports can be put in place to offer another level of support to people who have survived trauma? These very, very simple principles can be applied to any system. And in fact, so much of the sort of evolution in developmental services, from, you know, aversive to non-aversive to positive behavior to person-centered, that has run very parallel to this development of a trauma-informed mindset. The difference being is that we are explicitly considering the impact of trauma as part of that equation, knowing that trauma-informed approaches are not going to just benefit the people who have experienced trauma. They're going to benefit everyone. And in my mind, if we can build trauma-informed systems, what we create is systemic empathy, which means that even when we're not paying attention, the system defaults to empathy for what people have experienced, instead of us having to course correct away from another kind of systemic default. Being able to create a trauma-informed environment maximizes learning, innovation, collaboration, community building. All of those things are heightened. Why? Because trauma-informed supports allow us all to live in the learning brain. The learning brain is the brain where we make friends. The learning brain is the brain where we build relationships. The survival brain makes everyone look like a threat. The survival brain makes me worry that the time of, you know, the care worker in my residence, it makes me view it as a finite resource that either I can have or somebody else can have. And so it sets up a competition, whereas the learning brain is not fearful that there's not enough. The learning brain is ready to adapt and to share, to build community. So what happens when we use a trauma-informed approach? So these are just some of the suggestions to kind of get you started thinking. So one of the most important things we can do to help people get out of the survival brain is to create an environment where, whenever possible, people are going to be informed of what's going to happen. And when that's not possible, people are going to be consistently offered a chance to process the sudden change. And so if people know that whenever you can, you're going to let them know when change is coming, and whenever you can't, they're going to be supported in any of the feelings they have about that sudden change, that helps people to get out of that survival mindset of anticipating the next threat. Again, we see trauma responses, trauma reactions as protective actions and not problematic behaviors. When people act out aggressively because they are operating from a place of suspicion, we know that suspicion is a step on the path to trust, and that this is their brain's best way of protecting them and helping them with survival. And we validate that. We demonstrate real empathy, and we recognize that even when we don't know what the trauma is, because if we look at it from the perspective of the brain, the details become pretty unimportant. But when we look at what the impact is, we know that it's rooted in some pretty deep psychological pain. I think one of the most important things, and something that I also have on the list for when we talk about COVID for a few minutes, is that people have real choices. And what a real choice says is, here are two things. You can choose either one, and no matter which one you choose, I stand behind you. I will think that you did the right thing. I will feel proud and strong behind your decision. It's common in life that we are offered fake choices. Like, well, you could do that, I guess. Like, you could do that other thing, but it's going to be bad, and it's not going to turn out well, and you're probably not going to get that job, and people are, we set up all these things. So what we're saying in a fake choice is, here are two choices. You can choose either one, and I'm waiting to say, I told you so. The problem with fake choices, and we get offered them all the time, is that fake choices mirror the experience of trauma, because trauma in so many ways is a fake choice. We get through a trauma, we get through an accident, and we think back to what we should have done differently to prevent the accident, what we should have done better to make the outcomes less devastating. We think back about all these things we could have, should have, would have done. And people spend a lot of time stuck in that place because trauma tricks us into thinking that we could have chosen survival or something else. When in reality, if we've survived the trauma, we made the right choice. And so we want to make sure that people are getting real choices, and that if there aren't real choices to be offered, we're not offering them. I think sometimes it feels good to say, well, this is what you have to do. I mean, I guess you could do this other thing. But really, if there's no choices, we want to make sure that people know that there isn't a choice to be made, rather than offering a false choice. Okay. A few other things. Emphasize the belief, because it's more than a belief. It's a reality that individuals with intellectual and developmental disabilities can heal from trauma and can be part of a recovery process. That we focus on resilience and recovery. That we don't think about trauma as something that goes away. We think of it as like an old sports injury, that it acts up from time to time. Sometimes we need to give it a little love and a little babying. We need to nurture it. And sometimes it goes into the background. And that's what we're working towards. We're working towards trauma being part of our life in that way, but not always kind of overshadowing. We want to point out resiliency factors. I think this is especially important when I'm working with families. Families will come to me and feel like they just don't have the right things to offer the person that they love. And so we start talking about all the things that they do have, all the support that they have, even if it's just two people. When we're talking about trauma and recovery from trauma and the fact that attachment is important, attachment is one person. Attachment doesn't need to be 100 people. It needs to be one person who's emotionally attuned to what's going on. We look at coping skills. We also look at cultural aspects, traditions, religious or spiritual factors, all of those things as resiliency factors. I think it's also important to know that any kind of trauma is an experience of loss. It's a loss of the thing that didn't happen instead. And so validating that experience of grief and loss as a process of grief and loss. Even though we would like to think that people get over, grief with like 2 personal days or whatever, grief we know, and we've been able to identify it gradually as a society as something that's ongoing. And so if we think about trauma as a form of grief and loss, we can allow that time. And so as we're focusing on the process of recovery, we want to think about this specific strategy, which is called neurosequential approach. And neurosequential approach, I referenced this on Tuesday, basically means that we think about trauma in the order of the brain. And so what I mean by that is if we think of the lizard part of the brain, that very primitive part of the brain that develops first, right? Develops first in utero. That part of the brain is nourished by really simple things like being safe, getting adequate nutrition, and being protected, right? So we start with the very basics of how the brain develops, and we target our interventions to those developmental stages. So when I work with somebody who I know experienced a significant trauma in early adolescence, what I can expect is that they didn't get a chance to do a lot of the things that other people are doing in adolescence, to test out kind of, rebellious behaviors, and then to have somebody say, I love you anyway, and, to test out limits. And so if we're pairing our interventions and our understanding of what's going on with what we know was going on developmentally, according to their developmental stage and age, that helps us to see where the gaps in people's needs are. I recommended on Tuesday, and it's on the resource list at the end of the presentation, the book, The Boy Who Was Raised as a Dog. And one of the most amazing things in that book is that what so many people need to recover, to be in the recovery process from trauma, is to learn how to dance and to have a sense of rhythm, because they missed the developmental time when they should have been kind of gaining balance and coordination. And learning how to dance and to have a sense of rhythm isn't, about performing on a stage. It's about lining up what the input that your brain's taking in with what your body's doing. And those whole body approaches are really helpful in helping the body and mind to process trauma. Okay, so I'm going to skip forward just a little bit in the sake of time. These are more suggestions for you, but I wanted to just say a few things quickly about trauma specific to COVID and to how everybody is experiencing this. First, I want to say that for all of you who are working and supporting, families, individuals, colleagues, your families, your loved ones, your community, I am thinking of all of you, and I'm so aware of how this COVID crisis has moved back and forth into the foreground and background of people's lives, and how people have had to adapt pretty fluidly and consistently to manage when it feels like a crisis, when it doesn't feel like a crisis, when it doesn't feel like a crisis for one person, but it is a crisis for their neighbor. And so I've put in here all kinds of suggestions for you, most of which you can just take for your own time. But what I want to really validate is that whether or not you sort of conceptually think of what's going on as a crisis, whether or not it feels dangerous to you in your life, one of the things that this has created is a sense of sort of constant novelty and newness in life, where experiences that used to be the kinds of things where we could sort of we could turn the smoke detector down pretty successfully, have now become smoke detector heightened. So what I mean is going out into the world and having to think about face masks, having to think about social distancing, having to think about hand sanitizing, hand washing, both for ourselves and for the people we're working with and supporting, keeps our brain in this constant challenge of adapting to newness. And just like I said on Tuesday, that when my cat saw a pair of new shoes, he was terrified and puffed up. When we see things that are new, that don't fit into our perspective and into our perception, our brain revs up. So I think that acknowledging that that's happening is important, because it means that all of the things that we do are taking a little bit more mental energy than they once did, and that there can be a mental toll for that. I've really encouraged people to think of everything that you're doing right now as taking 1.5 times as much time as it used to. Not that we can always create enough room for that, but I think that that's about the toll of it, to make sure that we're allowing time for us to kind of cope with the feelings of it. And again, I'm not saying that all of us have this emotional panic, but the body panic of it, you know, just the experience of wearing a face mask, it's breathing differently. And when we talk about the things that keep our body healthy, which in turn keep our mind healthy, it is those basic things like breathing. And so I think just factoring in this reality is important. I've put in some suggestions in here just as ways to think about supporting yourself, supporting those that you work with. But what I also want to point out is that all of us in all our roles in life, professional, personal, and otherwise, are being asked to pivot and create a new way of being. And we think about what we need to create new ways of being. All of those things live in our learning brain. And many of us have spent a lot of time over the past few months in our survival brain. And so when I kind of put together a list of like, ideally, what would we be like to innovate our way through what's happening, it's all the things that happen in the learning brain. So when we think about being trauma informed, we think about the supports that we put in place, it's also going to help us through what's happening right now. The more we can acknowledge the stress, the more we can recognize that it's happening, the more our brain will adapt to it. You know, when you think about this warning system, the warning system in our brain, the smoke detector, is going to keep us alive no matter what. And in some ways, the more we try and tell our brain, I'm not scared, I'm not worried, even though our body is, you know, sort of sending off these alarm systems, it confuses the whole process. But if we say, this feels stressful and that feels unsafe. However, I know I've done this thing, and this thing to keep myself safe. I'm as safe as I could be in this moment. So I'll leave the other slides for you to look through. These are all just sort of practical suggestions for you. And obviously, I kind of overestimated what could happen in an hour today. But those are all resources for you. And certainly if you have any particular questions, I'm available for that. Okay. So I just wanted to see if anyone had any questions for me in these last few minutes. And I'm sorry I didn't quite leave enough time. But I'd be happy to take any questions that you might have. While I give everybody a minute in case people are still coming up with things, I want to say what I've included in the presentation, you have my email address here. I've included a list, like a selected list of my favorite resources. If you would like more resources, I have, you know, I can send you all the lists that I use in my trauma course. And then there's a ton of online resources that are really helpful. If there's anything else that I can provide, please let me know. And I'll also say I got 2 emails yesterday asking about the course that I teach at HCC. So I do teach a trauma course there, and it is part of the Developmental Disabilities Direct Support Program at HCC. So that's a program that was created in partnership with DDS. Direct support workers are able to take advantage of that program. It's almost fully covered by DDS. It's just $50 a course. So if that's something you're interested in, you can please email me offline and I'd be happy to send you that information. Okay, so my only question is when some of our folks do not have any worries or concerns and then see all of the changes in their lives as we reopen. We are being proactive, but so many of them are in the reactive part of their brains. This is a great question, and I think something that a lot of people are navigating. So I have a few suggestions that I have been using myself that I think can be really helpful. First, I think it can be really helpful in preparing people if when you're out and about, you just in a completely no stress environment in the grocery store, just doing normal things, if you take a video. because a lot of the images that are shown in the news, wherever, are in some ways heightened, or in one way or another heightened or polarized. But taking videos of people engaging in their normal activities, what it looks like for people to socially distance, what it looks like for people to wear masks, and being able to show those resources. Now, if you're working with people who are not sighted, I think it's equally helpful to talk to different people, and to have them talk about what it feels like to be out in the world, and to give a lot of different perspectives. I think telling people that it can feel weird to wear a face mask, and it can feel panic inducing for some people who aren't expecting that the face mask might sort of, contract when they're breathing. So practicing doing those things, talking about how it makes you feel, that if you feel a little nervous, like this is what this is the way that you're calming yourself down. So I think treating it as though we're learning something new, treating it like a lesson to prepare people, so that when it happens, it's like more of like a practice than like an all or nothing, like this is going to be great or terrible. But this is just like a practice. We're going to just keep practicing, learning this new skill. It's going to get a little bit less stressful as we go on. Okay, so email address, yes, is in the PowerPoint slide here. I also have my email address at Holyoke Community College. If you wanted to email me there, is the same, ahrovat@hcc.edu. Let's see. Is the course part of all the DDS programs? I think that this is a course that we have just recently added to our program. So I don't think that it's part of all of the certificate programs. All of the certificate programs have the same core, and then they have different classes from there depending on the program. So I don't know that other programs don't. We haven't had our coordinating meeting in a while, unfortunately. So I would definitely encourage you to look into it, because all of the programs are incredible. How would a therapy session look with someone who isn't verbal or chooses not to speak? So for me, those therapy sessions look like finding what works for them. A lot of the interventions that are specifically supportive of trauma are very body focused interventions. They're creativity oriented. In fact, whether or not somebody is verbal or chooses to speak, it is not uncommon for me to have sessions with people where we're not communicating verbally. And so we use a lot of art. We use a lot of sort of body movements. If they are comfortable and consent to some level of touch, we, a lot of times will use sort of like hand holding for them to indicate to me levels of stress and discomfort. A lot of interventions a lot of the trauma interventions that have some role of, telling a part of the trauma and then processing it can also be done in other ways by, asking a person to think about something that was scary and then to process it through their body. So we do a lot of muscle relaxation, a lot of sensory activities. The one thing that I'll say about trauma therapy in general that I think is what makes it different than other ways of coping is that the goal is really to help people be in the present moment with the thing that's difficult and to know that they can be okay. And so unlike maybe if in another time in life, like if we're out and somebody is really upset and we want them to just kind of be able to contain it for the moment, we might say like, think of a beach, like think of things that calm you down, think of things you're grateful for. Those things take people out of the moment. In the therapy session, we want to help people be in the moment as much as they can maintain and know that they're safe. And that can be done even without spoken word. I've worked with a number of nonverbal clients, and I hope, they've reported to me that it has been helpful to use these other sort of body and sensory activities. Okay. So I'll just answer this last question. Would you take the same approaches with people with dual diagnoses of IDD and a personality disorder? I think it would depend quite a bit on the presentation of their specific personality disorder. What I will say is that the correlation between people diagnosed with personality disorders and people with extensive trauma is very, very high. And so when we look at, for example, borderline traits or antisocial traits, those are very closely connected to a way of processing trauma and managing trauma, especially in like the way that people might kind of gain power over their interpersonal interactions. So I think I would employ a lot of, I would still, for me, I frame sort of everyone's experience through the lens of trauma. Like that's the place that I start. And I think about how, the other diagnoses, the other traits that they're dealing with might be supportive or protective of their experience of trauma. And then I work from there. I mean, for sure, it's very common for me to work with people who have extensive trauma histories and personality disorders. And it kind of depends like where they are in their life development. I think it's always possible to help people make that connection between the experience of danger and developing a protective pattern. It kind of just depends like kind of how far they are or where they're at in their ability to recognize, some of how these traits come up in relationships. There's a few great books and articles that have been really helpful to me in that way. So if you want to email me, I'd be happy to share those with you. Okay.
All righty then. Well, I want to thank you, Allison, for a terrific 2 days in terms of learning about trauma, and especially with people with intellectual and developmental disabilities, just so important. And thank you all for attending. Just a reminder that I did send out the slides for the 2 presentations on Tuesday. So if you didn't get them, just email me at Mahoney, M-A-H-O-N-E-Y, @arcmass.org. And also, this has been recorded, so it will shortly be up on our YouTube channel, most likely by the end of the week. So thank you, Allison. Thank you for all your great work. And we'll see all of you soon, I hope. Okay, take care. Bye-bye.
Thank you, everybody, so much. Take care.